Hello, everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, welcomes you to the second in a special series of NDEWS Presents webinars highlighting the global drug early warning system. The NDEWS PI is Dr. Eric Wish, and our NIDA project scientist is Maura O'Brien, and hopefully they are both with us in the audience today. My name is Erin Artijani, and Barbara Kerr, Mara Al-Nasser, and I will be the facilitators for this webinar. We are part of the NDEWS Coordinating Center team. For those who are interested, you can find detailed information about NDEWS, recordings of prior webinars, and invitations to future webinars on our website at www.ndews.org. You will also find instructions for how to join our NDEWS network and participate in ongoing discussions with more than 1,600 experts and concerned citizens from across the United States and many other countries. This webinar will feature Dr. David Newcombe, representing GDEWS, and experts from Australia and New Zealand describing the methods used in their drug early warning systems, the challenges and successes they have encountered, and the lessons they have learned. It will be approximately 90 minutes long, and we encourage you to submit questions during and after the presentations. Please post your questions in the Q&A box. Don't try to use the raise hand feature, things like that. We want you to submit your questions in writing, and we will see them and either answer you directly or they will be answered live by our presenters during the webinar. And we will hold a brief Q&A session after each of our presentations today. And our panelists, Barbara, Marwa, and I will do our best to get to all of your questions. If we don't, we can also post a transcription of the Q&A on the website, ndews.org, where we will also be posting a complete recording of the webinar and copies of the slides for each of our presenters. So we certainly hope that you will enjoy the webinar, and we look forward to any questions or comments you send in to us. I am now pleased to introduce Dr. David Newcombe, Senior Lecturer for Alcohol and Drug Studies at the School for Population Health and the Center for Addiction Research at the University of Auckland. He will provide you with an overview of the mission and goals of GDEWS. So, David, I'll pass it on to you now.
Thanks, Erin, and greetings from Australia and New Zealand. And I'd like to welcome you all to the second webinar in a series of the looking at drug monitoring systems. In particular, in this session, we're going to be focusing on systems in Australasia. So what I'd like to do in the next few minutes is just give you a bit of an overview of how this global drug early warning system project came about. And fundamentally, the activity around scoping a drug early warning system in New Zealand, which I'm very happy to be part of, led to initial collaborations between the Centre for Addiction Research at the University of Auckland and the team at the Centre for Substance Abuse Research at the University of Maryland, College Park. And part of this was to apply for a Distinguished International Scientist Award, a DISCA, from NIDA to assist us working together. So it allowed me to go to the University of Maryland, College Park for a few weeks to help establish this project. So the idea of the project is to examine some exemplars of drug monitoring systems from around the world to get a better understanding of how they work, get some idea of the context in which they operate, and describe areas of best practice. So the ultimate goal is to be able to help develop some guidance, some resources on this proven practice for people in countries that are trying to support the establishment and development of new drug early warning systems. So we have a number of outputs. The project plan, part of it, of course, is to present these series of webinars. We've already had one from North America, this one from Australasia, and we have one planned to showcase some exemplars from African nations. Other products will be some academic articles, but I guess more importantly will be this resource on best practice and guidelines for setting up the new drug early warning systems. So for today, this session, we are featuring two great presenters. One, Associate Professor Chris Wilkins from the Social and Health Outcomes Research and Evaluation and Whariki Research Centre from Massey University in New Zealand, and who will be representing the New Zealand system, and Associate Professor Lucinda from the National Drug and Alcohol Research Centre at the University of New South Wales in Australia, who'll be talking about some of the Australian systems they operate. So I'm really happy to be able to hand over now to Dr. Chris Wilkins, who'll talk about some of the systems that he's been operating for quite a while in New Zealand. So I'll come out and allow you, Chris, to carry on. Thank you.
Thanks, David. And thank you for being invited to here. It's a real pleasure to be part of this group and have an opportunity to present what we've been doing in New Zealand in terms of drug monitoring. So our drug monitoring system is called the Illicit Drug Monitoring System. Quickly, just an overview of the presentation. So I just want to talk a little bit about drug use in New Zealand and how that's characterised how we've gone about drug monitoring. Talk a bit about the design principles of the illicit drug monitoring system, and then really present just some of the findings in regard to new drug use, synthetic cannabinoids, a little bit about crystal methamphetamine because that's such a big problem here, and also a little bit about illegal drug markets. And the idea is those results will really illustrate the kind of things we've been doing here. Okay, so quickly, I'm sure you'll know where New Zealand is, but just to give you an idea about how we fit into the world geographically, we're in the South Pacific. And as you can see, we're a fairly geographically isolated country away from some of the major trade routes, and that has affected how drug use has evolved in New Zealand. And just close up here in more detail of the map of New Zealand. So in this presentation, I'll actually talk about the three main centres, Auckland, Wellington and Christchurch, and you can see those marked there. Okay, so as I said, I mean, the geographical location of New Zealand and its demographic population have really affected the types of drug use we've experienced. So we've got a small population, very isolated from many of the main global trading routes. So that meant that actually drug use in New Zealand was fairly low level for a long time. So we had cannabis, some heroin, but really heroin has never really been quite a big problem here, and the same, so very different from other countries. We also don't have very much cocaine, and the explanation for that is really that we're quite far from those smuggling routes, so we haven't really had those problems. So really our hard drug use problem didn't start until the late 1990s when we saw the emergence of methamphetamine, which could be produced locally, so it avoided all those problems with been quite separate from the rest of the world. And also we got some MDMA, some ecstasy. And then things got quite interesting in the mid-2000s, and again reflecting our isolation from the standard drug supply routes, as we had this big phenomena of legal highs, which essentially were products that could be produced locally, and they were substitutes for things like the poor supply of ecstasy, and poor supply of things like cocaine. So in some ways, New Zealand really led the world in terms of legal highs, and that was a pragmatic response to poor supply of other drugs, or poor supply of heroin and cocaine in particular. And then later on in the late, we had a synthetic cannabinoid emerged, mostly initially as legal highs in the, well, so-called legal highs in the sense that they weren't outlawed yet. And then the other major policy change that you might be familiar of from 2013 to 2014 was the Psychoactive Substances Act, and that was quite an innovative approach where we attempted to develop a regulated a regulated legal market for legal high type products, so low level psychoactive products. And really that response also, as I said, reflected our early introduction to the problem of legal highs and new psychoactive substances and the scale of that problem in New Zealand compared to many other countries. And then more recently, since 2014, we've had a second wave of methamphetamine, which is more crystal methamphetamine in the sense that it's imported methamphetamine, as opposed to the first wave of methamphetamine in New Zealand, which was locally made methamphetamine. And then we've also had a second wave of more potent black market synthetic cannabinoids, which really came about because after the Psychoactive Substances Act was, the interim regime was ended in 2014, essentially all these products that had previously been regulated were made illegal, and we basically opened ourselves up to a black market, and we've, like many countries around the world, we've experienced these quite potent new psychoactive substances. Okay, so we actually designed the illicit drug monitoring system in 2006, which feels like a long time ago. And in terms of drug monitoring, it really is, given the kind of dynamic environment we've got now. But when we set out to design it, we were very fortunate because we had some really successful Australian models, which Lucy Burns will talk about in the presentation after this one. And they really gave us a great model about how we should go about monitoring drug use. We wanted to focus on high-risk drug use. So in New Zealand, the high-risk drug users were methamphetamine users, as I said. But we also had this injecting drug use population, which had moved from internationally supplied heroin, which had become quite short, to diverted opioids. So at the moment, so diverted morphine mostly, but also what we call home-baked heroin and all these kind of diverted pharmaceutical opioids that were coming from the health system. We also, my background was in economics, so I was really interested in markets as well. So part of our monitoring was not just use and harms. We're really interested in markets in terms of prices, search time, and the types of drug markets. So one of the things that I thought was really important was the difference between private drug markets and public drug markets. From public drug markets like open street drug markets, drug houses where the neighbourhood was and the community was affected by those markets more than if they're private. Our emphasis is really on first-hand information from drug users. So, and I guess this is different for all different countries, but in New Zealand, we really didn't have the statistical sources. I mean, I'm always impressed by the US toxicology, drug poisoning data they have there, but we really didn't have that kind of really comprehensive statistical sources. And the other thing about interviewing drug users is the good thing about interviewing drug users is you really get first-hand information. So it's an opportunity to talk to the source of issues, which over time we actually thought was giving us the best data. And another feature is because we're a small country with small resources, rather than having a drug monitoring system for each type of drug use like that happens in Australia, we decided we'd do one drug system and we'd interview 3 types of drug users at the same time. So we had meth users, ecstasy users, and injecting drug users. And one of the reasons, rationales for that was we recognised that although we called these people methamphetamine users or injecting drug users or ecstasy users, though in reality they were actually polydrug users. So all those 3 groups use cannabis, they all tended to use LSD and some of the other legal highs. So it seemed like a very efficient way to go about it, that if we interviewed all 3 groups, they could comment on a whole lot of different other drug markets because they weren't exclusively using one drug type. We went for 3 major city locations, as we saw on the map previously: Auckland, Wellington, and Christchurch. And really, I mean, this is not a very impressive diagram, but essentially, I mean, and what this triangle in the middle should be filled with is other drug types, so cannabis, ecstasy. So it's the drugs that all these 3 groups use as well, and they therefore can comment on those, the availability and price of those drugs as well. Okay, so a bit more statistical analysis. So we really thought that we should make an attempt to do some statistical analysis and look at trends over time, rather than, although we clearly recognise that these weren't representative samples, and you know, so it wasn't strictly speaking that easy to apply statistical analysis. The other thing we did is we did weight the sample, so we decided, yeah, we were actually pretty interested in looking at trends over time. So, and one of the things we tried to do is make the sample quite consistent over time. So that meant weighting the sample in terms of numbers of meth and ecstasy and IDU to the same proportions through the years. I mean, it didn't really make that much amount of difference, but we felt that it added just a kind of a layer that was quite useful. And kind of another slightly more controversial thing we did, and as I said, we were really working off the model, the Australian model, and so a lot of their scales were categorical scales, and we so for example, availability, you could score it from very difficult to very easy, and there was 4 categories. What we thought is, just to make that scale more easy to look at, we decided to firstly enumerate it. So we gave very difficult a score of 1, very easy of 4, and we had 1, 2, 3, 4. And so when we presented the data, if we wanted to look at availability, we calculated the mean for that availability, and that allowed us to do a whole lot more statistical testing. We were pretty, you know, we were aware that probably that wasn't strictly statistically the way you do it, given they're categorical scales. We understood that, but again, we're being pragmatic in terms of trying to present the data in the most easily digestible way. So they were categorical, but they were also, you know, we could see that they actually were a scale, so we could add numbers to it just to make it easier to follow. And you'll see that when I start presenting the findings, how we feel that kind of makes it easier to understand what's going on. The other thing is, so we decided to present the market findings by location. So rather than trying to present a whole national New Zealand results for availability and prices, very clearly, very early on, we saw that the drug markets are very local. So one thing we were very focused on was prices, but prices varied quite considerably between our locations, and you'll probably find that the same for your own countries. But it was particularly clear in New Zealand. So we presented all the market data, availability and price by the location, but we presented the harms data, the demographics, dependency by the drug user group, because again, they were so different. So methamphetamine users are very different from ecstasy users. Okay, so this is essentially the IDMS aims, the kind of things that I've talked about: tracking trends, documenting availability and price, finding emerging drugs that became a more important part of it as we went over time, and identify changes in the structure of drug markets, and we thought that was important in terms of the harms they generated, and then document health and social harms of drug use itself, and then access to health services. So I won't present everything, but you know, hopefully you'll get a flavour of what we've been doing. So essentially what we do is we survey 300 frequent drug users every year from the 3 different locations, and they're roughly 100 meth, 100 ecstasy, and 100 injecting drug users. We're not too hung up about the precise numbers, and again, as I said, we do weight that sample to try and, when it comes to statistical analysis, just to show, you know, provide some consistency and rigor there. And so we recruit all the frequent drug users from street level. Or probably more accurate to call it community level. So we work with a whole lot of community partners. So the needle exchange here was particularly important to access injecting drug users. But we also work with a whole lot of other community groups in terms of leaving flyers and being able to recruit people that way. And over time, those relationships developed, and so people knew who we were, and they helped us out quite a bit. And so what we do in the interview, so the interview lasts about 45 minutes, and the people that approach us, they report their own drug use and harms, but they also talk about key market indicators. So sometimes I describe the participants as, a good analogy is real estate. So the way this works, as I always say, is that if you want to know what the prices of the house prices in your area is, you could go about two ways. You could actually seek out all the prices for the houses in your area and try and calculate the average and how that had changed. Or you could actually just go straight to a real estate agent and ask them, are prices going up or down? And for us, the drug users are like our real estate agents, that they are particularly well informed and have expertise in drug use, and they know what's going on. Okay, so now I'm just going to go through and just give you a quick overview of what the kind of data we have. So this is the levels of this is the percentage of the entire frequent drug user sample that had tried a drug for the first time. So as you see that from 2010 onwards, there was a little bit of an increase, and that represented most likely synthetic cannabinoid use. But the interesting thing is, once we broke that statistic down by the 3 drug user groups, we see here that somewhat surprisingly is the most innovative drug users, or most interested in new drug use, are actually the ecstasy users, and the meth users a little bit. And again, all this was driven a lot by new synthetic cannabinoids. But injecting drug users are actually the most conservative in terms of new drug use. And that reflected that, of course, that they tended to be just purely opioid users, and they were dependent opioid users. And this is just, so looking at the ecstasy users themselves, who, as I said, were the most diverse and most readily interested in new drug use. If we compare synthetic cannabinoid use here, you see the percentage that were using it for the first time really went up quite steeply from 2009 to 2011, and then it actually declined over time. And it was slowly replaced by going back to ecstasy. So like many places in the world, we had problems with global supply of ecstasy, but that's come back in recent years, and that's illustrated in this graph. Okay, so and we've got an interesting situation in terms of synthetic cannabinoids, because as I said, we had the initial wave of so-called legal highs. We had a regulated market in 2013. We had the ban of all legal highs, and now we have a black market. So, so if we look at current availability, and again, so this is the first illustration of how we present the measures. So we've 1's very difficult, 4 is very easy, and we have an average. So in 2013, when it was part of the regulated market, it has a very high availability score. After those products were banned, there's a fall in availability, and then in 2015 in the black market, it's somewhat reduced as well. But the interesting thing is we look at change in availability. So again, 1 is more available and 3 is easier. That in 2013, it was pretty stable. 2014, there was this big becoming more difficult. But then in 2015, the availability actually recovered. And I guess this reflects the development of the black market and the recovery in that market after the banning of all products. Another interesting aspect of this is, again, in terms of strength, when we had the regulated market in 2013, strength very high. Initially, after the bans, there was a decline in the strength of synthetic cannabinoid products, but in 2015, there was actually this quite big recovery in the strength of products, and that reflected the introduction of these more potent black market products. So it was interesting to pick up all those changes. One of the big things, big problems in New Zealand has been methamphetamine. And we've been tracking methamphetamine, as you see from this graph, for a number of years. And we've gone through different waves of methamphetamine use. So this represents the 3 different locations, Auckland, Wellington, and Christchurch. Current availability, and again, so this is the average score of availability. And you can see there's been some changes. So an interesting thing here is Christchurch had a major earthquakes in 2011, and that really devastated that city. And you see that that really affected the market in terms of decline in availability of methamphetamine. But as that city got rebuilt, and a really big factor was you suddenly had all these construction workers that came in and rebuilt the entire city, there was actually an increase in availability of methamphetamine, and we really picked that up as you got this influx of young men in the construction industry seemed to drive demand there. Okay, so another, and this graph looks really crazy, but and I mean this isn't a really sensitive measure, but it's actually quite interesting measure. It's the purchase time. So we ask people, how long will it take you to purchase a drug? And we have a scale from weeks, days, all the way down to less than 20 minutes. And this graph shows how many percentage of people said they could purchase methamphetamine in 1 hour or less for the 3 centres. And it goes all over the place, but actually it's quite, even though it looks quite, there's a lot of variation, it's actually quite useful. So if you follow the green line, you can see that as in the previous graph, the earthquake had this big impact around 2010, 2011, and then you suddenly got this return in the market as that city was rebuilt. And if you look at the blue line, that also shows that steady increase in availability in Auckland as we got the second wave of methamphetamine. Another focus has been prices. So as an economist, I think prices are actually a really useful way to monitor markets. And this looks at the price of a gram of methamphetamine. So again, this tells a really nice story about how there was basically the price was steadily increasing up into 2010, and that represented quite a big focused enforcement and policy approach to methamphetamine called the Methamphetamine Action Plan. But suddenly around 2010, 2011, we had this quite large drop in the price of methamphetamine, and that represented that increase in global supply in this region. So the UNODC has said that the quantity of methamphetamine supplies to East and Southeast Asia quadrupled around this time. And this was really reflected in that quite steep price decline of nearly $200 per gram. And this is, I mean, just to illustrate that was the actual price, but this is the measure, which essentially is the price increasing or decreasing. And again, you can see consistency between those two measures. And this shows, again, the decline in price of methamphetamine in the 3 main centres. And so there was this consistent decline in price in all the 3 locations, representing that this is a global supply increase of methamphetamine, not just a local factor. The other thing is, so we have 2 types of methamphetamine, the local made methamphetamine, which I just presented on, and then we have what we call imported crystal methamphetamine, or ICE, which comes from mostly South Asia and China. And again, we saw another story of increasing supply here. So from about 2011 to 2012 onwards, there was this increase in supply of ICE, which had previously been kind of a niche market in the methamphetamine market. And again, it's illustrated in the price here that, as I said, in 2011, crystal methamphetamine is really kind of a premium methamphetamine product, and the price reflected it. So it was much more expensive than the locally made methamphetamine. But after 2011, there's this slow and quite dramatic decline in the price, representing this greater supply of imported crystal methamphetamine. And again, this is just the categorical measure which illustrates the change in price. Okay, so all those measures of availability are telling us that there's been this increase in methamphetamine, and in particular an increase in crystal methamphetamine, and related declines in the price of methamphetamine and crystal methamphetamine. So, and our measures were picking up these changes in 2014. So, I mean, I know anyone involved in drug monitoring, particularly from the research angle, always is confronted with some skepticism from audiences where they say, well, we're not picking that up, or we're not seeing that. So particularly in 2014, there was some skepticism about really whether there was this increase in supply. But this graph's really, really terrific, because it eventually shows, this is the kilograms of methamphetamine seized in New Zealand over quite a long time. And you can see in 2014, 100 kilograms, it's pretty consistent with the rest of the years. But then in the last 2 years, we've had massive, huge increases in seizures of methamphetamine. and that has really corroborated the findings that we'd previously found through our drug monitoring. So we felt that this is really great, that it really did confirm we're picking up some real trends, but it also showed how lagged the drug seizure data was. So you didn't really find out there was a change if you looked at drug seizure data in 2015, even 2016, but our results were picking up changes as early as 2013, 2014, so we felt really good about that. And another interesting thing about that is if you looked at the number of meth labs detected, it was actually this massive decline ever since 2005, 2006. And that really just illustrates how sometimes secondary statistical sources can be a little bit misleading. So this showed, but what this really represented was that change that I talked about, the change from domestically made methamphetamine to imported crystal methamphetamine. So once imported crystal methamphetamine turned up, the number of local labs actually declined quite considerably. So, you know, this measure is actually telling you that the market switched. It's not that methamphetamine in general declined, but it's just the type of methamphetamine changed. And again, another illustration of that point is these are tablets of ephedrine. So ephedrine used to manufacture methamphetamine. So you see there's massive seizures of ephedrine, pseudoephedrine, but then in 2006, this big decline, and that again represents if you're not making methamphetamine locally, you don't need pseudoephedrine and ephedrine, you're just importing crystal meth. Okay, as I said, another part of that I thought was important in terms of drug monitoring is looking at the structure of drug markets. So I thought this question about types of seller was important to us because it was the difference between, as I said, private drug markets, which were transactions in houses, and open drug markets, which were either street drug markets or drug houses, which were imposed all these nuisances on local communities and also violence as well. And this shows basically over time how the sellers of meth, how the methamphetamine market tended to get dominated by organised crime and gang members and drug dealers as opposed to private kind of friend social acquaintance markets. And that was really important in terms of the impact on the community of that market. And another illustration of that point, much more starkly, is we looked at the types of sellers that sold illicit opioids, mostly morphine in Christchurch. And remember we talked about the earthquake in 2011, and this really shows the difference between before the earthquake and after the earthquake, and it's quite an interesting effect, was the earthquake seemed to disrupt the private personal drug markets that were the dominant market supplying illicit morphine before the earthquake, but after the earthquake, this was replaced by a more organised market supplied by gangs. So the red line shows the percentage of people who bought illicit morphine from gangs, and as you can see, it was all declining all the way into 2011, and then suddenly there's this massive increase after the earthquake, and to a point where most people bought their illicit morphine from gangs in Christchurch. And there was this decline in the green dotted line of social acquaintance, which was more a personalised network. The red line was actually drug dealers, whereas the blue line here is gang member, but both drug dealers and gang members increased quite steeply after the earthquake. And that has really important implications about the impact of those drug markets on the community and local neighbourhoods. Okay, and this is location and meth purchase, and again, this is quite important in terms of that distinction between private drug markets and open public drug markets. So you can see here increasing public or semi-public drug markets like purchasing from a park or a public area, or what we call a tinny house, which is just an open drug house, or a street drug market. So there was this quite large increase in percentage of methamphetamine users who are buying from street markets as opposed to kind of private houses and social acquaintances. So the percentage buying from the street market increased from only 5% in 2009 to 23% in 2015. So that really showed how the methamphetamine market became entrenched in quite an open market in recent years. And so injection of methamphetamine here, another kind of important thing is showing another quite distinct transition here from methamphetamine is largely was initially largely smoked in New Zealand, but in more recent times we see increasing of injection, and that's an important public health change to take note of. Okay, so what are some of the take-home messages? I guess for us, you can see we've got a unique geographical location and demographics context. So I think some of the advice I would give is design your monitoring system to fit your social demographic environment, and also the availability of other statistical sources. So we were really felt that we didn't really have a source of really great statistical data that we could use, so we relied quite heavily on interviewing drug users. Stay flexible in design and adapt to what works. So we really have adapted this. So in 2006, it was very different from what it is now. Over time, we really emphasised different parts of the drug monitoring system, and we adapted it to what we see was working and what was affected. Embrace new methodology. So even though we were very focused on interviewing drug users, we also have become interested in a whole lot of other things like wastewater analysis. We've been doing quite a bit of that, and from drug treatment, from sewage treatment plants, and also we've been looking at monitoring online sources and looking at NDEWS. We can see they're on the similar track to us in terms of trying to embrace those new methodologies which are addressing some of the new challenges in markets like new psychoactive substances. As I said, we believe drug users being a source of expert knowledge and experience that is actually really important to use in terms of drug monitoring. It's also an opportunity to engage with them and show them the kind of services around their area. So there's also some public good part of that as well. Pick secondary data sources carefully. So as I illustrated, some secondary data statistics are actually really good, but interpreting them is actually a really big challenge in terms of getting that right in terms of wider drug trends, because they all have their own things going on. As I said, we put, I think, prices of drugs can be a really good market indicator source if you can interpret it correctly, and that is one of those really good objective sources of data. Be pragmatic, so we've been really pragmatic about statistical analysis. So some of the stuff is not strictly of academic quality, but really we've acknowledged that our audience is not an exclusively academic audience. It's actually quite an agency-based audience or the public audience. So we're really just trying to find the best way of communicating findings in an easy to understand way. And finally, get buy-in from stakeholders. So as I said, we've worked really closely with community groups, drug treatment groups, community action groups, and also places like the Needle Exchange in particular. And they've been really, have really worked with us quite closely in terms of recruiting drug users, and also helping us out in terms of what particular issues we should be looking at. So that's it, and thank you.
All right, thank you very much, Dr. Wilkins. We certainly appreciate that presentation. You shared a lot of valuable information, and we did have a few questions come in, so I'm going to just read them out to you and give you a chance to respond to them. The first question is from an attendee who would like to know if your survey of approximately 300 drug users, are those 300 separate people, or is it possible for the same person to fall in multiple groups, such as MDMA and IDU?
No, they're separate people. So, I mean, that was a little bit of a challenge, but essentially we had three different types of recruitment material. So people tended to respond to the recruitment type that they were most comfortable with. So they would ring us up and say, I saw the methamphetamine material, or I saw the injecting drug use material. And it was pretty easy to see once we started talking to them before we started the interview, what type of drug user they mainly identified with. And we had a bunch of interviewers. So an interviewer would usually only interview about 20 odd people. So it was pretty clear when they were, I mean, they knew when they were, that person would only be interviewed once.
All right, thank you. Our next attendee would like to know, were you able to get a sense of overall emerging drug use via the in-person interviews, or was it only info limited to a single point in time?
Well, I didn't really present it, but we actually had a whole lot of open questions where we asked people about new drug use, what new drug trends they'd seen. So we were providing an overview within the last 6 months. So, and they had an opportunity to really describe the kind of things they were seeing.
Okay, and our next question is from somebody who would like to know if you follow up with the same sample each year, or if you start over with a new sample.
Yeah, again, these are all challenges that we were kind of, we were interested in trying out, but that was really the way we looked at it. So that was possibly a way we could have gone. But we felt that because some drug users actually had quite short drug using careers, so we'd really lose quite a lot of the sample over time quite quickly. And also we were not so, and people develop through their drug using careers. So if we interviewed the same person over and over again through time, yeah, it would be good in terms of looking at some trends, but they would mature out of drug use. So, and we really wanted a snapshot. So every year we wanted to make sure we were interviewing active drug users. So we decided to stick to cross-sectional design.
Okay, thank you very much. And our last question wants to know if the study period includes the time during which crypto markets emerged and became globally active. Were any related questions included in your surveys, or were crypto markets mentioned in open-ended responses?
Yeah, and again, crypto didn't really present that, but we have a whole section on crypto markets, which we've been expanding in the last couple of years. But one of the locations where people could buy drugs from was the internet. It didn't so much affect methamphetamine, which I presented, but if we look at ecstasy, the percentage that bought from the internet has increased from, well, essentially 0% in 2009 to about 10% now buying from the internet. So we're slowly picking up that effect.
Okay, thank you very much. I appreciate you answering all of those questions. And we're going to move on to our next speaker now, and I'm very pleased to introduce Dr. Lucinda Burns, who is Associate Professor at the National Drug and Alcohol Research Centre at the University of New South Wales in Australia. So Dr. Burns, if you could unmute yourself and pull up your presentation, we're ready for you.
Yeah, I'll just get my presentation up. Can you see that?
Very good. Yes, we can see your slides. Thank you.
Oh, wow, well, that's a good thing to start with. Okay, yeah. Look, thank you very much. What I'm going to be doing today is, I guess, leading on from Chris, because we do share actually quite a few similar, I guess, methods and findings. We are located quite close to each other, although we do have substantial differences as well. What I'm going to be doing is telling you a little bit about how we monitor drug trends in Australia, although at the moment our methods of monitoring are actually going through a process of change, and with the rapid escalation of the internet and all these newly synthesized drugs, we're trying to get something that's even more real time. But that's something I'll go on to talk about shortly. As mentioned, I work at the National Drug and Alcohol Research Centre, where I suppose I've been specialising for a number of years in examining the epidemiology of illicit drug use, but also drug use within the more marginalised populations, such as people who are homeless and women. But that's not the point I'm going to be talking about today. We're fortunate to have ongoing funding through our federal government for this program of work, which has been going for really more than 20 years now. So it's been built on and changed over time, and that's really what I'm going to be addressing today. So to give you an outline of what I'm going to be talking about, I'll briefly give you a snapshot of the aims of our program as they currently are, although as I've mentioned, we're going to try and get a more early warning component in. Look at how we go about monitoring those drug trends and the methodology we used, including interviews with, as with Chris, people who use drugs, both people who use injecting drugs and people who use more recreational psychostimulant use drugs, and also some interviews we have with key experts such as health and law enforcement, indicator data, and then our newest component, which I suppose addresses some of the crypto market questions. We do go in and have a program of work where we look at both the surface web and the dark web to see the sorts of drugs that are being sold, and then I'll try and pull that together in terms of where we're going next and what this sort of this findings that we've had locally mean for the processes. So when we look at the aims of the program as it stands, we really, this has been going, as I said, for a long time, and our aims are really and at the moment, is to detect changing patterns of use, but also the harms associated with that use. So things like overdoses, hospitalisations, rates of death, patterns of treatment use, etc. Again, we on an annual basis document both for the price, purity and availability, self-reported by these people of illicit drugs. And we also include indicators where we have some forensic analysis of pills that are seized annually. And so we can actually see the components of those pills. For example, what used to contain a large amount of ecstasy now only contains a very small amount of ecstasy and a lot of rather unpleasant fillers. Our aim then of the work is also to point to where we might need more specialised or detailed research. For example, we might be, at the moment, it seems we also have a methamphetamine issue, but it seems to be that our methamphetamine problems are largely or are also coming from different, non-traditional drug markets, that we are now seeing these substances used in rural and remote areas where we haven't traditionally had a monitoring program. So that's something we need to look at. That's an example of the sort of area that we'll be looking at now. And this really does, because we are funded by government, we try to provide a pretty rigorous evidence base for drug policy. So our outputs include things like reports, bulletins, government briefings, which we do pretty quickly when they're needed on note. For example, ministers, parliament. We provide an annual conference where we distribute our most recent findings. And we have a lot of, it's quite a mixed representation at our conferences. So we have a lot of policymakers, people in practice, and also health and law enforcement personnel. So it's quite a diverse output there. And that's an example of some of the reports we have been producing. We do quarterly bulletins on topics of particular interest. annual national reports and annual jurisdictional reports, although all that is now going online, and we're trying to get a nice interactive website where people can just go, media, school children, people who, government, everybody can go and get exactly what they need from this particular portal. So when we look at how we put our measures together, and it's very much, our system is very much about triangulating information from a number of different sources to see whether we're getting the same picture or whether in fact we're getting a more diverse set of information from one source to another. So we do things like examine our population surveys. We have a triennial series of a household survey that contains information about drug use, and actually now contains information about the new synthetic drugs as well. So we look at drug use patterns there. As I've mentioned, we use secondary indicator data sources as well. So things like cause of death, hospitalisations, presentations, criminal statistics, arrests, etc. We include other technologies, although we don't go out and do the work on this ourselves. We do collect or collate information from other sources, such as biological samples. We work closely with people that do the wastewater analysis and some blood analysis from other sources as well. Our newest component, I suppose, that we put on in the last 5 or so years is actually to do with internet monitoring, and it's drugs, new and emerging technologies. And we call it drugs, new and emerging technologies because although largely we're focusing on the internet at the moment, we always try to scan the horizon for what will be a new mechanism by which people will be either producing or distributing drugs. So we constantly scan both the domestic and the international horizon for new technologies. And as I mentioned, we also use other population surveys, and sometimes these are targeted surveys such as the Gay Periodic Surveys, needle syringe program surveys that we have here, but also our own Sentinel sample surveys, which I'm going to talk about next, which are our surveys of people who use drugs, the IDRS, illicit drug reporting system, and the EDRS, which is the ecstasy and drugs related reporting system, though I should mention that that is really now more broadly a psychostimulant system because we're not sort of based, so because with increasing use of methamphetamines, we're not really sort of broadly just solely looking at ecstasy as a base market there. So I just want to tell you about a little bit about the way we began our system, and it really began in the 1990s, and it responded, I suppose our government responded to, we were having, I suppose, what you could call an epidemic of heroin overdoses at that time. And in particular, our Prime Minister's daughter was involved with heroin use. There were consequent overdoses and deaths, and this became a significant public health concern and really proved a challenge to how we might go about setting up and monitoring drugs in illicit drug markets. So in the beginning of the 1990s, we had a criminologist started piloting something to look at illicit drugs, but that program at that time proved a little cumbersome. It was a new project and wasn't very timely. So we were commissioned or commenced commissioning in 1995 to start building a program where we could design a system to actually monitor of drugs, monitor a system to look at drug trends in Australia, but looking both at use or self-reported use and the harms associated with use. So the first system that we set up was something we call the illicit drug reporting system, and that was piloted in the 1990s. And what we did started off in one particular state, New South Wales, and as time developed or advanced, we took on more and more states to become a national system in about 2000.
So that involved a number of face-to-face surveys with people who actually inject drugs. We did qualitative interviews with key experts, and these would be people in law and health areas such as needle syringe programs, particularly key law enforcement, police, who would be able to tell us what they were seeing and what they felt were the drug particular trends going on. And that was, as I've mentioned, a more qualitative process. And as I've mentioned, we also use the indicator data to tell us what was going on there in terms of arrests, overdoses and things. But of course, the problem with this sort of indicator data is that, as Chris has mentioned, there is a significant lag. So, it's, a year or even more for deaths where we have a big lag there. So we play catch up a bit with our indicator data, not so much our treatment data, but certainly the harms data. So the next thing that we really saw in terms of our system was the rise of ecstasy, which of course became quite a significant issue in the 2000s, where I guess the first instance was that our key informants and the people that we were interviewing would tell us that they were starting to use or see the emergence of these new, I guess, stimulant type substances that weren't actually being captured by our surveys that looked at people who injected drugs. Both our key informant data, which is qualitative, and we can ask them about what's going on, but also, interviews, face-to-face interviews, we have sections where we say, is there, what else is on the scene at the moment, and then the following year we can actually turn that into a categorical question to ask whether they've used that particular substance or not. So it's progressive, and we take those things into account. But when we looked at the EDRS, which is the sister system, these were now drugs that look things more like ecstasy, but also LSD was a little bit back on the market. And these were drugs that were more likely to be, I suppose, swallowed, snorted or smoked rather than injected. And they were used in different sort of venues, more social venues such as music scenes and nightclubs. We ran this particular system, the EDRS, on the same process or methods as the IDRS, except rather than interviewing people who inject drugs, we were interviewing people using the criteria of being regular ecstasy users. So, just as my mouse. Okay, so as I've mentioned, the methodology and what was to, firstly, we do interviews with people who use drugs, and we, being a national sample, we would interview approximately 100 to 150 people within each jurisdiction in Australia, which gives us a national sample of up to about 900. We would interview key experts in health, law enforcement and treatment services, and the entertainment industry, for example, for the EDRS. And we'd also add to that the indicator data, routine population surveys and administrative data sets. And their whole, I guess the whole reason for using all that diverse set of information was to triangulate things so that would overcome inherent weaknesses in each particular source. So we hoped when we put things together, they would be telling us much the same picture. If we look then briefly at, how we would differentiate the screening and eligibility for people who might inject drugs versus people who would be using drugs more in a social scene. We do screen people via phone. Initially, we now use Facebook as the primary advertising route for people to recruit them into our studies. So for the Injecting Drugs Centre, we also use treatment services to screen people there. So we look for the injecting drug, whether they're injected in the last 6 months. whether they've been in the same geographical market for the past year, and this is how we get what we call a sentinel sample. They're in that market and they can tell us about what's been going on in that market. As I said, we sample them. A lot of these sampling we do for injecting drug users or people who use inject drugs. We sample them from NSP services, clinics, and then we ask them to nominate other people, or to actually ask other people to contact us, whether they are other people who might be injecting drugs. And as I've mentioned, that gives us about 100 participants from each jurisdiction. With the psychostimulant use, which was previously based on ecstasy, but is now a broader psychostimulant criteria, it's whether they've used that particular substance in the last 6 months. Again, whether they've been in the same geographical market for the past year. And we advertise, well, previously, now we're really much more on the web, but largely at this particular point in time, we'd be advertising things like street press, universities, and again, that snowballing of asking people to ask other people to contact us. And again, that gives us about 100 participants in each jurisdiction. So we look at with respect to people, generally our samples, as I've mentioned, we do face-to-face surveys with these people. NDARC, where I work, manages a number of jurisdictions where we don't have a chief investigator, but our other jurisdictions we outsource that to a particular. What we do is have manage the whole program from NDARC, but we have chief investigators in some of the other jurisdictions who will subcontract to undertake the interview work and then send the data to us. And that's a good collegial. It's very important to have this national collegial collaborative process happening. And again, we get about 100 in each capital city, and they are capital cities. And I'll stress that because we do lose out on rural and remote, and that's becoming an issue, more of an issue, particularly when we see that methamphetamine is being used in other areas, and we're not capturing that particular group at the moment. Neither do we actually capture cocaine very well using these systems. I think it's a different. For example, cocaine is a different group of people. They're really not, we do pay people to participate in our surveys, a small amount of reimbursement, but people who are using cocaine wouldn't generally need that, and they've probably got more likely to have positions where admission of any drug use they may feel would jeopardise their particular situation. So we need to look at other systems to examine things like cocaine. But with the people that we do recruit, we try to standardise things, so we recruit people at the same time each year, and that's a matter of keeping our trends going. So when we look at the drugs of focus in terms of the drugs that people inject, of course these change again over time, but traditionally what our contract has us look at are the major drugs of interest, heroin, cocaine, methamphetamine, cannabis, and other opioids. Other things like we have a more diverse group set up within the EDRS, and I'll talk a little bit about those in a moment, but these are the traditional drugs we looked at in the IDRS. Just want to get a little bit of a snapshot of the people that agree to participate in our injecting drug use surveys. They tend to be an older group, and they are getting an older progressively. We're seeing this group getting older each year. They're largely male, often unemployed, single, almost half currently in treatment. Quite a substantial, about a third have been arrested, it's early in the morning here, arrested, and the mean age is about 20. But what we're finding also from other indicators that we're not getting many new entrants into the heroin market at the moment, and that's shown through the the fact that we are getting an older cohort of people who are injecting drugs, and that's even taking out the ones that have been repeatedly interviewed over time. This is just an example, a recent, I suppose, shot I wanted to show you about the changing sort of drugs that we pick up through the injecting drug users that we interview. And as I've mentioned here, what we're seeing, in fact, is that we're getting a bit of a leap up of the crystal methamphetamine injection with the stability in heroin. And I think this is really important, and Chris mentioned this, because a lot of the public health programs of methamphetamine are related to people who are using other routes, snorting, smoking, but we haven't really focused on injecting drug users. And I really feel that this, whether because they're a smaller group, whether they're more marginalised, they're not as much of as much public interest, but this is really a problem because this group, if they're injecting, they're more likely to share, etc. So I think we, as a public health broadly and internationally, this is a group we really need to spend more focus more attention on. Again, this shows that, in fact, if we look at how frequently they're using, again, we are finding an increasing number of people who are injecting weekly or more, so almost half here. So we're also seeing not only they're using more crystal, but they're also injecting more often. As I mentioned, we also look at harms, and we do have a whole bunch of harms, mental health, various other things, but I've only just taken a picture here to show you what we look at in terms of injecting risk behaviour. And here, if you can see here, we are making some headways in terms of sharing. So if we look to comparison from, this is only just a snapshot from, for example, if we look at 2004 to 2016, we can see decreases in people borrowing, lending a needle and sharing equipment. And we have been doing a bit of paying attention to trying to get the message across about, in fact, reusing one's own equipment, and that does seem to be showing a decrease as well here, and that's equally important for things like sepsis. So I think those are generally good indicators, and that's what our face-to-face survey can tell us as well. I want to turn now briefly to the psychostimulant program of work, which looks at things, and again, this is a program, I suppose, that changes in terms of the sort, we have to keep adding on new drugs to look at within this survey. So at the moment it's based, was based on ecstasy when it was first introduced, and we look at cocaine. As I've mentioned, it's not a great source of data for cocaine. Methamphetamine, which is our drug of concern here at the moment. Cannabis, which is something we really often neglect because it's so widely used. But, as we do know, now cannabis is becoming more and more potent, hydroponic cannabis, and there's more and more research showing harms about cannabis. So I think we really do need to pay, significant attention to cannabis. LSD, as I've mentioned, has had a resurface. Ketamine and GHB were on the scene more about, 10 years ago or so, but they've taken a bit of a backseat now to the novel psychoactives, which I'll talk about in a minute. I want to just focus a little bit here about how these differ to the people who we saw were injecting drugs. As you can see, when we thought they're about, almost half the median age of the people who are injecting drugs. Again, they're largely male, but they're much less likely to be unemployed. They're also much more likely to be students. And these are the drugs of choice here. They're also far less likely to have been incarcerated. So they're much younger, student type, and these are sort of people who will be taking drugs in a social recreational setting. Again, this I think is an interesting trend. I just picked out a few interesting trends that we're finding recently from this particular survey. and that is the form of ecstasy use that we've found now is changing from pill form, whereas we can see, you know, a definite decrease in pill forms, but we are now seeing quite a substantial increase in the proportion of people self-report taking their ecstasy in a crystal form. Of course, this is self-reported, it's not based on forensics, but it's something we've been seeing consistently. Again, although we're tending not to rely on this, and we're going to change our methods of key expert interviews perhaps to have a panel, because we find that doing individual key expert interviews isn't working so well. But generally these are people who've been in good contact, regular contact with people who've been using these substances, and they have a good knowledge of the markets. There, for example, law enforcement can tell us what's coming in, customs data, seizures, and also people, if we look at, you know, as I've mentioned, people who work in the treatment industry, outreach workers, and law enforcement type people for injecting drug use. Also, I should mention consumers. We've got, and I'm very neglectful not mentioning that we do have quite strong consumer input from, we have a number of quite strong advocacy groups in Australia, and we consult them as well. The EDRS really is more focused on the young people in the entertainment industries there. So we look at things like people who might work in that industry, people who might, for example, might be providing aid at party scenes and that sort of thing. We tend to use these, do these interviews either by telephone or face-to-face interviews, and we traditionally did about 20 of these interviews in each capital city. Finally, when we look at the indicator data, this is where we, for example, might look at, this is a particular pattern again of heroin overdoses, and as you know, we can see here changes, for example, in heroin overdose to emergency departments where we might get a decline here. And, you know, we have seen, as we know, we did see a big dip in our heroin markets here in Australia in about 2001. And so following that, we did see a significant decrease in the presentation of overdoses. So we have indicator data to include in our triangulation as well. In terms of the actual sort of information we get from our indicator data, we use things like death data from coroners, illnesses from hospitals. We do, as I mentioned, use those routine household surveys, look at ambulance call-outs to overdoses and emergency department presentations, and other things I haven't put there, such as treatment services, use of the opioid substitution treatment presentations, that sort of thing. So more recently, of course, we've been challenged and we will continue to be challenged by the internet. We now really have what I would call drugs without borders, and our drug markets have become global. This means that what we have really face now is new methods of both production in big labs, small labs, bathrooms, enormous great tin places and sophisticated laboratories, and changes, of course, in the distribution of substances through the internet, and I will talk a little bit about doing that through websites. But what this means is that we have this whole new diverse range of drugs that are now available across the world, and it's a far less known content of those substances. So we're really facing new challenges with the rise of the internet now. And what we've started to monitor in the past, particularly is through our face-to-face interviews, is the rise of the new psychoactive substances. We know from the European Centre for Monitoring that there's a whole bunch of these new psychoactive substances that tend to mimic, our traditional substances, but they are synthetic and often very unknown quality. We don't really know exactly what's in them. And a lot of the fillers in them can be quite toxic in themselves. So as I can say, and this has just continued to grow up. There's more than 600 at the moment, I think, of these new psychoactive substances available. It's become concerned to the degree now in Australia where we actually also ask about new psychoactives and particularly synthetic cannabinoids in our triennial population health surveys, and as you can see here, we are getting about the same. Probably more people saying they use this than they are using, for example, drugs such as heroin. I mean, it looks low level, but that's quite substantial when you bring that up to the population level, work that up to the population level. In our particular EDRS or psychostimulant project where we asked about this, you can see here that we did see, I suppose, a major group of people that are saying these in about 2012, where we had a big concern. There was a lot of media about these. Legislation started changing. We took a lot of these drugs off the shelves of places where people could buy them. And there was a lot of enforcement of legislation, and so we've seen a bit of a decrease in the number of people trying these. And I would point out too that with these sort of substances, we get less people saying that they repeat use of these sorts of substances, that they're a much less pleasant sort of high that they get from using the more traditional type of substances. When we look at how often they actually purchase these online, we don't get as many. Other nations seem to have a lot of people purchasing these sorts of substances online, or saying through their surveys that they've purchased them online. We only had about 10% of our samples saying they purchase these sorts of substances online, or any substances online. Largely, we have a traditional drug market, so they will still be buying from their known dealers. The places that they do purchase tend to be far more from the dark web nets rather than the surface web stores. The sort of drugs that they're taking through these webs really, they're not. If we do, and I'll show you a little bit about our internet monitoring program, but traditionally the people are actually still purchasing the traditional drugs most often through the web, and these include ecstasy, LSD and cannabis. When we look at the type of novel psychoactive substances they use, they're ones that come from the 2CX, DMT and MBOBI family. And the issue around these substances, they often have quite a hallucinogenic effect. So these are the ones where behaviour is unpredictable and can be risky, but people often don't know at all what they're taking. So it may surprise them when they have these particular effects going on. So just finally, I wanted to tell you a little bit about our dark net monitoring. What we do is we do weekly snapshots of particular marketplaces, and we look at all substances listing, the retailer names, the price that people will be paying, and the country of origin where that's particularly possible. And because markets change so much over time, what we do is select markets with more than 50 listings, and we look at English language only. Of course, this is all based on the market, not on the individual who's purchasing from the market. And I just wanted to show you a little bit here. I'm going to do this. Yes, there we go. That in fact, that these are, again, just reiterating my point, that the drugs that they are buying from these markets, and I don't think these are the most recent markets, but they're pretty consistent in terms of the main things that people are buying there, and they are, as I said, your more common traditional substances such as cannabis, pharmaceuticals, ecstasy and methamphetamine. These are the top drugs being bought online through the darknet. However, again, just to emphasise this, the types of NPS, novel psychoactive substances that people are buying currently, and we have seen this a bit more consistently, whereas, you know, about 8 years ago, we were all worried about methadone. Now we're seeing these ones, the 2CXs, DMT, which of course was an old drug, but it's coming back again, and as the most recently highly ranked novel psychoactive substances that are being used. So putting that all together, I think it's fair to say that we have quite a comprehensive drug trends program, which includes the IDRS, where we interview people who inject drugs, and that's been going, you know, since in the 90s. We have an indicator program that collates overdoses, seizures, treatment data, and that's been going since the early 2000s. Once we saw the rise of ecstasy, we incorporated a component of the looking at regular psychostimulant recreational drug users. And more recently, in the past 5 or so years, we started monitoring drugs and new emerging technologies. And we've been looking at that through drug marketplaces online. We've also looked at some consumer websites, such as Blue Light and some other places where people who use drugs go to get health information and to see sorts of things that they'll be discussing there, though we don't have that analysis just at the moment. So pulling all that together, I think it's fair to say that, you know, really we can't rely on our monitoring systems keeping stable. They're highly variable due to a range of external individual drug characteristics. They're, you know, prone to change through famine, war, drug routes, who's actually at top of the hierarchy of drug production, how often people are exposed to information of drugs. And we've got to keep onto that by scoping the whole international scene to find out what's going on. I think it's fair to say that we've now actually moved from largely a plant-based set of drug markets with heroin and cannabis to a set of drug markets that has a vast array of chemically synthesized substances. And what that will require now is a system of monitoring that can detect both long-term and short-term changes. And with the short-term, and this is where in particular our, I suppose our concern from government is that we are going to see more and more short-term non-predicted epidemiological clusters of spates of drug use, for example, and even deaths at where particular batch of substances may be sold at things like dance parties, and we'll see some, you know, cluster of real problematic drug use there, and we need to be able to work at that to be able to, you know, detect or prevent that happening, whether that's through, I don't know, pill testing or whatever substance methods people might use, but that's something we really need to address. Because once these people get into hospital, they can't tell us what they've taken, and so the medical profession is really at a loss to know themselves and how to reverse or treat those particular outcomes. So I think if we put all that together, there is, you know, an ever-growing sophistication of our social communication networks, and I think it's fair to say that drug use now crosses all borders, and in particular, the message from all this taken together now is that international collaboration between policymakers, consumers, law enforcement, governments, law. It's just particularly vital that everybody's working together at this particular point in time so that we can start addressing these particular new and ever-changing challenges. That's about it from me. Just, of course, we need to acknowledge the particular participants. We're very lucky that people keep agreeing to go into our surveys. We have collaborators across the country, the researchers who work there, in particular people who've continued to fund our program of work. We've been very lucky that way. And if you need a bit more information, this is where we go. This website is still a little mystery to me, but if you go in there and look on drug trends, you'll be able to see reports and information. Okay, thank you.
All right, thank you very much, Dr. Burns. We certainly appreciate that presentation. That was a great deal of information, both about the process and the methods you used and about what's changed and what's going on now in Australia. So that certainly gave us a lot to digest and think about. We did have one question come in from an attendee who would like to know if you collect other demographic characteristics related to socioeconomic status, like annual income or education level, things like that.
Yeah, we certainly do. We have a lot of demographic information on that sort of thing. We don't tend to try to go into too much detail because it can put people off participating. So it is, yeah, we do have a lot of information, but we try to, I suppose, minimise a lot of that stuff because, as I say, the main crux here is to get a picture on what's going on.
Okay, thank you very much. I want to thank everybody for joining us this afternoon. We certainly appreciate your participation and the questions that you submitted. And I just want to let you know that our next in our series of webinars examining global early warning systems will feature speakers from 3 countries in Africa: South Africa, Kenya, and Nigeria. And we will be holding that with Dr. Newcombe next week on October 3rd, 2017 at 10 a.m. Eastern Daily Time. And so I certainly hope that you will be available to join us for that webinar as well. I think we're all looking forward to that one. And before we go, I would really appreciate it if you could take a few minutes for us and complete a brief poll just to let us know what you think and what you would like to learn about next, what other speakers we could feature and that kind of thing. So I have launched the poll and I hope that some of you will join in and fill in some of the questions for us. And Dr. Newcombe, I don't know if you have any closing comments you'd like to share.
Yeah, thanks, Erin. And I'd like to sincerely thank our presenters for 2 very good and comprehensive presentations. And I think what was clear, you've got 2 systems that are have similar methodologies but have evolved because of different geographical locations and different drug trends. And I think some of the messages were to be kind of flexible, embrace technology, and the need for collaboration. So I think those are really good messages that we can take from these presentations. And I would recommend that people do explore the websites from each organisation. They're very good and very comprehensive. So thank you from me. Yep.
All right. Well, it looks like a few of you have answered our questions. There might be a couple more trickling in, but I certainly second everything that Dr. Newcombe said. I certainly greatly appreciate both Dr. Burns and Dr. Wilkins, your presentations this afternoon. And we look forward to continuing our collaboration as we go forward.
Thank you.
Thank you. Pleasure. Bye-bye.
Yeah.
All right. Thank you, everyone.
All right.
Bye-bye.